Hello aspirants, I am Dr. MAHBOOB, MD Ophthalmology from AIIMS New Delhi and founder of Ophthalmology Wizard app. Today we are going to discuss Fmge July 2025 Ophthalmology Recall. And it is also very important for the NEETPG student because NEETPG is few days ahead and high chance of repeating from this Fmge questions. So without wasting time, let's start the session. This is the first MCQ where you can see a CT scan image and they have asked which wall of the orbit is fractured here. So you can see this CT scan image and what you are noticing here, there is a soft tissue prolapse into the maxillary antrum which is called teardrop sign, and this teardrop sign in a blunt trauma is a feature of what? Blowout fracture. So the blowout fracture will be the answer for this MCQ. Okay. Coming to this point to understand that which orbital wall, most common orbital wall to fracture in blunt trauma. So which is the most common orbital wall which gets fractured in the blunt trauma? The answer will be floor fracture. So this is a very important MCQ to understand. Okay. Coming to the second MCQ, let's discuss about the second MCQ. Can you see here? A patient develops a painful swelling. A patient develops a painful swelling in the eyelid with a pus point at the base of the eyelashes. Okay. Which of the gland is responsible? The gland responsible. Okay. Which of the gland is responsible? Option are gland of Cross, lacrimal gland, Guy's gland, and Meibomian gland. So look at the MCQ. What is they are asking? The pus point at the base of the eyelashes. Eyelashes के base पे pus point है, means the diagnosis here they are indicating towards what? They are indicating towards style, which is also known as external hordeolum. And now you know that the style or external hordeolum is caused by what? Caused by the inflammation of Guy's and Mole gland. So what will be the answer here? The answer will be Guy's gland. Got it? Coming to the explanation of this, so if you want me to explain all these things, I can show you this three picture. This three picture can explain you everything. See, the first picture, if you are noticing the first picture, that there is a pus point here at the lid margin, painful swelling. So this is painful. Okay. Swelling of the eyelid with the pus point at the lid margin. So this is what we call, this is called style or external hordeolum. Okay? This is painful and this is because of inflammation of Guy's and Mole gland. Okay? Now look at this picture. This lesion is, sorry, let me mark this lesion. This lesion is away from the lid margin and this is very reddish, that is meant inflammatory. So this will be painful away from lid margin and on the eyelid. That means it is nothing but it is internal hordeolum. It is what? Internal hordeolum. And this is caused because of the inflammation of which gland? Yes, of course, it is because of the inflammation of meibomian gland. Inflammation of meibomian gland. This is because of the inflammation of meibomian gland. Okay. So this is internal hordeolum. Now coming to this portion, can you see this? There is no redness is there, means inflammation is not there, but the swelling is there, which is away from the lid margin. This is called chalazion. What it is called? Chalazion. It is also because of what? Involvement of which gland? Meibomian gland. But this is not inflammatory, though this is painless. This is painless. And what we are calling here, this is a chronic lipogranulomatous. Chronic lipogranulomatous lesion. So this internal hordeolum and chalazion is because of the involvement of the meibomian gland, both of them. But the difference is, this is inflammatory and painful. This is non-inflammatory and chronic lipogranulomatous lesion. This is, you have to know. For NEETPG also you have to know. Okay? Take the screenshot. Now, coming to the third MCQ. Here they are saying that a myopic patient with the flashes and floaters having a deep anterior chamber. Flashes and floaters having a deep anterior chamber. What should be the diagnosis? The option are central serous retinopathy, rhegmatogenous retinal detachment, tractional retinal detachment, exudative retinal detachment. Mind you, I have made this option just for the convenience of MCQ formation. It is not the exact replica of what is being asked, what have been asked in the FMG, right? So, what should be the answer here? The answer will be, because the myopia patient is at the risk of development of the retinal detachment, higher risk of development of retinal detachment compared to that of the normal population, and that's why the answer should be here, the rhegmatogenous retinal detachment. Answer should be here, the rhegmatogenous retinal detachment, rhegmatogenous. Now, because I have told you myopia is at the risk of development of retinal detachment compared to that of the normal population, one thing, then why it can't be tractional, why it can't be exudative? Because most common type of retinal detachment which is happening in the myopia is rhegmatogenous retinal detachment. That's why the answer is rhegmatogenous retinal detachment. Now let's dissect each and every options one by one. अगर central serous retinopathy answer होता, तो what would have been extra here? Central serous retinopathy में they would have given you the steroid intake. History of steroid intake, one. Second thing, sleep deprivation. Third thing, stress. So these three F should be there to diagnose a patient with a central serous retinopathy. Plus, central serous retinopathy are usually younger patients who takes stress. Rhegmatogenous retinal detachment is the most common type of retinal detachment among all the retinal detachment. In the tractional retinal detachment, they generally give a history of diabetic patient. Right? If the diabetic patients are there, matlab retinal detachment, tractional retinal detachment, more common the diabetic patients. Third, for being an exudative retinal detachment, what should be the history? There should be a history of any inflammation. Inflammation का कोई history होगा. Whether it is ocular inflammation, whether it is systemic inflammation, like in the case of VKH, the sympathetic ophthalmitis, Behçet's disease, okay, posterior scleritis, this type of the inflammatory history will be there. Tuberculosis, right? So that's how you dissect a MCQ, okay? Now, you can see here the difference between when you have a picture of retinal detachment in the eye, then how to say that it is rhegmatogenous and it is tractional. Generally, tractional retinal detachment, you have this tent-like structure, something is pulling like a tent-like structure. And rhegmatogenous, you can see there will be generally a dome-shaped structure. A dome-shaped structure will be there. So this is the most common type of retinal detachment, RD. Now, coming to the next MCQ. An elderly patient with a complaint of painful loss of vision with redness, and on examination you have a mid-dilated. You have a mid-dilated vertically oval pupil. Mid-dilated vertically oval pupil is itself saying that there is something which is classical of what is called angle closure attack. So anterior uveitis, no, because in anterior uveitis you should have a history of AC cells. Okay, the pupil will be festooned pupil. I will discuss later one by one. So the answer for this question is generally acute congestive glaucoma, because there is an attack of acute angle closure. Okay, so the answer here will be this one. Now let's dissect it one by one. Why it is not anterior uveitis? For anterior uveitis, अगर ये anterior uveitis होता, for anterior uveitis, what should be the extra thing? One, pupil should be festooned pupil. It is irregular. It should not be mid-dilated vertically oval. Irregular festooned pupil. One. Second thing is that AC cells का history होता है. AC cells का history होता है. AC cells present होता है. Third point to understand. Why it is not primary open angle glaucoma? Primary open angle glaucoma. Primary open angle glaucoma is never mid-dilated vertically oval pupil. One. Second thing is that this is primary open angle glaucoma is painless. It should not be painful. No redness. No redness. Okay. Third is angle acute conjunctivitis. Acute conjunctivitis. In the acute conjunctivitis, what should be there? There should not be a history of decreased vision. Okay, there will be pain, there will be congestion, but no decrease of vision. वहां पे decrease of vision नहीं होता है. अब the question is why there is a decreased vision in angle closure attack. What happens if there is a mid-dilated pupil? Then this mid-dilated pupil will have then this mid-dilated pupil causes the pupillary block. This pupillary block increase IOP, and if this IOP is more than 50 or 52 or 53, then there will be stromal, means corneal stromal hydration, and this hydration will lead to the corneal edema, and this causes the decreased vision. So this is the cycle of the acute angle closure attack. So this is how you can explain each and every option. Now, coming to the fifth question, a patient with a painful ulcer in the eye. An examination, there is a linear branching ulcer with desquamated epithelium is present. What is the diagnosis? Bacterial, dendritic, or fungal? Basically, they have asked you about this painful ulcer. Maybe this I may be wrong with the this recall, because there is a lot of confusion. One of the students told me there is a linear branching. So with this help, I can tell you that the linear branching, what you see here, you will see only in a case of this. So you can see there is a linear branching here. There is a linear branching here which can ulcerate. So this is the answer will be the dendritic ulcer. Of course, in the fungal ulcer also there is a branching, but the branching is not so linear. Okay. Second thing, that in this viral keratitis there is a decreased corneal sensation. Okay, and the treatment will be topical acyclovir, or you can also give ganciclovir. Okay. Second thing is that if you have an epithelial involvement, no steroid. If epithelium is involved, because it can cause further ulceration. Got it? Coming to important point to understand here. Now, a patient using a contact lens develops the severe pain in her eyes. What is the diagnosis? A contact lens user, if anything happens in a contact lens user, suddenly go for the acanthamoeba keratitis, because the most classical question. So directly, without thinking, go for the answer, man. What is the answer? The answer will be acanthamoeba keratitis. Acanthamoeba keratitis. Okay. You need to understand one thing is that look at this two picture. So this picture is here. What is this picture is being shown here? So what you are seeing here in this picture, that this is a ring-like structure. So this is a ring ulcer. Okay. Here symptoms is more than sign, and this generally present in the contact lens user or dirty ponds में जाकर के भी ऐसा होता है. So this is nothing but this is acanthamoeba keratitis. Okay, this is acanthamoeba keratitis. One thing. Second thing to understand here is that the treatment is 0.02% PHMB, polyhexamethylene biconides, PHMB, right? One important thing I must tell you, that in the contact lens user, most common organism is Pseudomonas, and most specific if they ask, go for acanthamoeba. So generally acanthamoeba will be the answer, but if they are asking most common only, you have to go with the Pseudomonas. Don't jump to the answer, just see what they are asking. Now what is this? You can see the feathery margin here. So this is the feathery margin, okay. So you can see what is called feathery margin. So this is called hypopyon. Okay, this hypopyon with this feathery margin, we are having a diagnosis of fungal ulcer. Treatment is 5% natamycin drop. Okay, you can also have a satellite lesion here. This hypopyon is this hypopyon is actually non-sterile. Non-sterile, right? Now, coming to the next MCQ. The next MCQ is this one. A patient came to the clinic and Hirschberg test has been performed. So this is the Hirschberg test that has been performed. What is the prism diopter of this, all these things? So 15, 30, 45 and 90. See, the pupillary light reflex is here, and in this eye it is at the margin of the lid. In this it is at the margin of the lid. Okay, at the margin of the lid. It is at the center, it is at the margin of the lid. So the answer could be what? Let me tell you this Hirschberg test. Can you see this Hirschberg test here? If the light reflex is at the center, it is 0. If it is at the pupillary margin, it is 15 degree. If it is at the middle of the iris, it is 30 degree. and if it is at the limbus, it is 45 degree. So in this MCQ it is at the limbus, so it should be 45 degree. And you know that 1 degree is equal to 2 prism diopter. So the answer will be 45 into 2. Let me tell you, 1 degree is equal to 2 prism diopter. So since this is here, this is 45 degree, means 90 prism diopter. So the answer will be 90 prism diopter. You got my point? You got my point, right? Means if it is at the limbus, it is 45 degree. Since 1 degree is equal to the 2 prism diopter, so the answer will be 90. Now coming to this, patient presents with the left eye ptosis with the eye being down and out, right? What is the diagnosis? Third nerve palsy, fourth nerve palsy, sixth nerve palsy, seventh nerve palsy. The patient is simply, let me tell you here only. Here only, let me tell you that, as you know, there is a LR6. Lateral rectus is supplied by the sixth nerve. SO4. Superior oblique is supplied by the fourth cranial nerve. Since lateral rectus is causing outward movement, right? Outward. And superior oblique causing the downward movement. So the question is saying there is a down and out. Down and out means both of them are working. Rest of the muscle is supplied by third cranial nerve along with the levator palpebral superioris. LPS also supplied by the third cranial nerve. So LPS is also supplied by the third cranial nerve. So the ptosis is actually happening because of the third cranial nerve palsy 1, and because there is a down and outward movement of the eyeball and the rest of the extraocular muscles is actually not working, only sixth and fourth is working. That is why there is an outward and downward movement. And so the answer will be, clear-cut answer will be here is third nerve palsy. It's a very classic question. There is nothing if and but here. You have to mark it like this. Got it? Now, which is the finding? Here, see, a very simple, that which finding is shown in the image. You can see this image. Just see the image. After seeing the image, tell me the finding fast. A very fast finding here, that after seeing this, you can have a finding here of a shallow depression. You can see shallow depression here. This is the shallow depression called Hirschberg pit, which is seen in trachoma. So the answer here is Hirschberg pit is seen in trachoma. Very good. Okay. Now, what about Panus? What about Horner Stantag spots, and what are the art lines? Let me show you this, all these things, because this is very important. Can you see the image? Look at the image. Here, there is a tiny raised lesion. Where? Can you see this marking? These are the tiny raised lesion. Tiny raised lesion. What is this called? This is nothing but this is Horner Stantag spot. Now, coming to this, can you see here what you are seeing here? Can you see here? What is this? This is subconjunctival linear scarring. This is nothing but this is Alt's line. Okay. Now, can you see this? What is this? This is nothing but Panus. Sorry. A Panus. What is a Panus? What is a Panus? A Panus is corneal neovascularization with infiltration. अगर इन्फिल्ट्रेशन भी है और न्यूरोवेस्कुलराइजेशन भी हो रहा है as seen in the cases of VKC, then this is called pannus. Okay, this is called pannus. One, this outline is seen in trachoma, and this hornet antage spot is seen in the VKC. So these all photos are very important. Okay, coming to the 10th number of MCQ, a known case of pituitary adenoma, very classical example, which is compressing over the optic chiasma. Okay, now what is the visual field defect? A very classical, if something is pressing over the optic chiasma and optic chiasma is pressing, it's a bitemporal hemianopia. No if and but, nothing to be just showing. Bitemporal hemianopia, how it will look? This one is gone. This one is gone. This is called bitemporal hemianopia. So anything, if there is a compression of the optic chiasma, there is a bitemporal hemianopia rule. Beyond optic chiasma means optic tract, optic radiations, cerebral cortex, occipital cortex, sorry. All of them is involved. There is a homonymous hemianopia. And if the visual field, like right homonymous hemianopia, I am saying the patient is having right homonymous hemianopia, then what will be the, where will be the lesion? It will be the left-sided lesion. Or if I am saying left-sided homonymous hemianopia, where will be the lesion? It will be on the right side. So this should you know. Okay. Coming to this, the patient, this question is very classical, have been asked in the previous year. PYQs. They have given this image and they are asking what is this image representing, which refractive error this image is representing. This is what? Anyone just imagine what is this? This is called Sturm's conoid. Actually, this is a vertical rays of line. This is the horizontal rays of line intersecting at one point called D point and then again diverging. So this is the Sturm's conoid. Since there are the two different light ray, vertical and horizontal, itself is saying that they are the two different meridian and their patient is having something called astigmatism. So if there are the two different meridian having a two different pictures like this, so the answer will be astigmatism. Got it? Now, what in the NEETPG examination they have asked? They have given this MCQ. They have given this MCQ in NEETPG. Okay. In NEETPG examination, they have given this and they have asked which is the circle of point of least confusion. So among all these things, which should be the point of least confusion? The places where the rays are not diverging from each other. Not means the place where there is a least divergence. So this is the place where there is the least divergence, and this point is the point of least confusion. So this is also an MCQ. Remember, point of least confusion. Coming to this one. The question is saying the 40 years old person is having a difficulty. I mean, not difficulty, I'm saying is having a pupillary normal reaction is not there. Means when you touch the light, there is a no reaction to the pupil. But when the patient is seeing some near object, there is a pupillary reaction. Means the light reaction is present, the light reaction is present, pupillary reaction is absent, but accommodation, because he is seeing the near object, so accommodation reflex is present. Where is the lesion? Means, let me tell you, the patient is saying, this question is actually saying that pupillary reflex absent, accommodation reflex present. So where is the lesion? Lesion kahan hai? So by looking at this, what is the diagnosis? The diagnosis here is Argyll Robertson pupil. So the answer will be where? See, oculometer, optic reading where? So answer will be pretactal. Okay, because Argyll Robertson pupil happens, matlab is because of the lesion in the pretactal nucleus of the midbrain. Okay, let me give you a short example of some pupillary reaction thing. Can you see this? When there is a no light, no reaction is there, right? When there is a no light, there is a no reaction. Okay, got it? When there is a no light, there is a no reaction here. But when the light is flashed here, the pupil reacts here, pupil is reacting here, and pupil is also reacting. Consensual reflex is also there. But when the light is flashed here, the pupil is not reacting. Also, there is a no consensual reflex. Means there is a no afferent, no efferent pathway. Okay? So it is positive RAPD, and what is this type of pupil called? Right-sided. This is called Marcus gun pupil. And where is the lesion here? Lesion in the optic nerve. Optic nerve. In this case, right-sided optic nerve damage is there. Okay? Got my point? This is Marcus gun pupil. This is Argyll Robertson pupil. Pupil reacts to the light. Pupil reacts to the light, but not. Sorry, pupil not react to the light, but reacts to this accommodation portion. Okay. One point to note that here there is a no anisocoria. Okay. So if I say ARP, you can read it like accommodation reflex present. From this direction to this direction, accommodation reflex present. And from here to here, if you read pupillary reaction absent. Example is in the syphilis, or we can say neurosyphilis is the example where you can see the Argyll Robertson pupil and Edinger-Westphal nucleus is involved in this condition, right? Coming to one more nucleus that you need to know is this one. You can see there is a, let me give you a proper view of this. Can you see the pupil size is this one and pupil size is this one? There is a gross anisocoria, right? When there is a light reflex is there, nothing is happening. Again, if there is a light reflex, the thing is happening something. So light reflex is absent. That means light reflex absent. Same in the case of Argyll Robertson pupil, light reflex absent. But when you are bringing this to the list, to here, accommodation present here. Accommodation present. But in Argyll Robertson pupil also, there is a pupillary reflex absent, accommodation reflex present. Here also, light reflex absent, accommodation reflex present. What is the difference then? In Argyll Robertson pupil, there is no anisocoria. This is called edystonic pupil. Edystonic. Why edystonic? I will tell you. So in edystonic pupil, one, there is an anisocoria. First difference. Second difference, when there is accommodation reflex is happening, the pupil constrict very slowly. It is not so slow in Argyll Robertson pupil. Here, with this, pupil reacts very slowly. And after accommodation over, pupil expand also very slowly. This is not the case in the Argyll Robertson pupil, and that is why, because the tone of the in this edystonic, the tone is very slow, rigid, constrict very slowly, dilate very slowly. That is why it is called edystonic pupil. Okay. Now Coming to this question, FMG 13. Posterior staphyloma is seen in high myopia, hypermetropia, posterior scleritis, dyscoloboma. The answer is straightforward because posterior staphyloma is a hallmark of high myopia. Yes. What is posterior staphyloma? It is a thinning and outpouching of the sclera, posterior sclera. So high myopia is the hallmark for posterior staphyloma. This have to be remembered by everyone. In each and every class, every ophthalmologist will teach you this. Just rat jao. Don't think that you are going to have a apply your brain here. No brainers. A patient suffering from Wilson disease. So patient is having a Wilson disease. So what are the parameters that you do to diagnose a Wilson disease? A very straightforward question. To diagnose a Wilson disease, what should be the parameters? Serum ceruloplasmin, ferritin, or vitamin D? Obviously, the answer will be serum ceruloplasmin. No one should get it wrong because you have to remember serum ceruloplasmin will give you a parameter of the patient is having a Wilson's or not. In the Wilson's disease, Kessler-Fleischer ring, KF ring, is the ocular finding, most important ocular finding that you have to remember, ma'am. Okay, so in the Wilson disease, also what you see, KF ring, okay, detachment. A 15-year-old boy with a history of severe itching, recurrent redness in the eye develops the condition shown in the image. Here, as a sequelae, patient को recurrent redness है, patient is having recurrent redness, very severe itching, बार-बार होता है. और because of this, there is a sequelae of event takes place, and this is the picture what you are getting in your OPD. What is the diagnosis? Sealed ulcer or bacterial ulcer? Straightforward question है, हमेशा पूछता है, PYQ repeatedly asked. ये एक VKC का क्वेश्चन है, so answer is sealed ulcer. ये पेशेंट VKC का है. Why VKC का पेशेंट? Vernal keratoconjunctivitis. क्यों? Because of, if you see, there is a recurrent redness, recurrent itching, diagnosis of VKC. So many times VKC have been asked in so many forms. So VKC is a very important topic for FMG, right? This is what we call a sealed ulcer. Let me give you a photo of what happens in the in a VKC vernal keratoconjunctivitis. You have horner plantage spot, as we have already discussed. You can have, after a sequence of events, multiple times, not treating well, doing again and again, allergic inflammation, right? There is an ulcer formation called a sealed ulcer, and also there is a depression can also be formed at the limbus that is called pseudogerotoxon. Okay, and this is the last question of FMG, that a patient having a spectacles of +12 diopter which can see 612 with the both eye, what should be the lens status, whether this is phakic, pseudophakic, aphakic, and cannot be guessed. Phakic मतलब क्या होता है? What do you mean by phakic? A patient having a natural lens. I am phakic, you are phakic. If a patient gets a cataract surgery and an artificial lens is placed, this is called pseudophakic. And if a patient is having no lens, natural or artificial, no lens in the eye, it is aphakic. Suppose the normal power of the eye, the normal power of the natural lens is generally considered to be what? The normal power of the eye generally considered to be 17 diopter, right? Around 17 diopter. So this power of the lens is placed into the posterior capsule, right? That is sulcus. Posterior capsule. There is a capsular fossa. As we go away from the posterior capsule, the vertical vortex distance increases, so the power is also decreases, right? So the spectacles comes down to 12 or 10, right? Since the patient is using +10 or 12 diopter glasses, that definitely means the patient is having some big refractive error, and this type of big refractive error is generally seen in a case of aphakic when there is no lens and because there is no lens, patient has to wear a +10 or above power of glasses to see clearly. So obviously from this condition you can have a answer of aphakia. This way we come to the end of FMG question. So I hope you like this session. Okay, do subscribe, and my Telegram channel link is there. Do subscribe and go for this for ophthalmology. Thank you very much.